So in communication skills, there are two station, preparation station and exam station. In phone call specifically, here you can use your pen and your paper. So in the preparation room, you will find instruction outside the exam room. This is the preparation station. And inside the exam, you will find a file that contain all the patient details, the history, the examination, the investigation, and the management. So how you can deal with this preparation station? There's some tips and tricks so you can help you. First thing, you have 9 minutes. So you should deal with this 9 minutes smartly. Take the pen and pencil, write your details. First, who you are. I am Muhammad Akasha or I am Muhammad Sadiq. Your consultant, working with or working under, and then the hospital. This is the first step. Your details, you should write it in the paper at the start. You will find your consultant and the hospital by opening the file. After the opening the file, you should read the patient history and the investigation and the examination and the management. By practice and reading from the school, you will master when you should look or where you will look to your investigations. Some like ITU or ITU registrar, you should look to the CRB, the white blood cells. By practice, you will know the investigation that you need to check.
We already provided a couple of files for the, I think they are very common now. Did you see these files for the communication skills?
Yes.
Yeah.
I will try my best to find another file that's from UK, but these files you will give an idea for how the session will go. Yeah, continue, Muhammad.
Yeah, after writing your details, checking the files, then write who you are calling. Is it ITU registrar? Is it a trauma head consultant? Is it vascular or other consultant? Then write your purpose. I'm calling regarding urgent patient, regarding referral, regarding update. The last thing you should write the patient details. Start from the history. Patient present by blah blah blah. Then write the examination, what the finding of the examination, then the investigation, then the management or the action that you did. So this is the 4 main points. Your details containing your rule, your consultant, and your hospital. Who you are calling by reading the file, who you are calling to, and then the purpose. I'm calling regarding a patient have dilating, widening mediastinum, the chest X-ray, the purpose. And confirming who you are called. The last thing, patient details from the history till the management.
There is a sad story, Muhammad. I don't want to interrupt you, but I want to say there's a sad story. One student didn't know who is calling, and then during the station, the examiner asked him who you want to speak to, and he forgot. And the examiner said, when you remember who you want to speak to, let me know. And the student sat there for the whole station, thinking that what he was supposed to do, and he missed the station basically. So let's say this situation happened to you. What you gonna do? Fatah Rahman.
Yes.
I'm your examiner. You are my student. I asked you who you want to speak to. You didn't know. I said when you remember who you want to speak to, let me know. What you gonna say next?
I will check in the file. It will be in the table. I will check the name, at least, or the prescription of the.
All right. Let's say you were very anxious. You were very stressed, and you couldn't find the file. But you know you don't know the name, but you know the consultant is a cardiovascular, for example.
Then I will again. I will apologize for inconvenience.
Yeah.
Calling the vascular consultant to update him about one of patient or referral or something like that.
All right, and but you forgot my name, doctor.
Sorry for inconvenience, but I'm trying to look for the name. I didn't find it in file.
Okay, go remember my name and then I will continue with you.
Apologize and ask him his name again.
Look, Fatah Rahman,
Yes.
whatever happens, you should, even if he said, remember my name, you should say, sorry, doctor, but I would like to proceed with the conversation. Even though I forgot the name, I will make sure I will remember the name next time. But I really need to discuss this patient with you for my patient safety.
Ah.
So if you forgot the name of the consultant, you shouldn't refuse, okay? And your main purpose, you want to say something, right? You don't want to miss the station.
Yes, of course.
So you do your best to push him to speak. You do your best. Even if he said no, okay, now I will proceed and I will tell you the history, and you continue. Don't ever stop, because if you didn't say nothing, that means you missed the station, okay? Yes, Mohammed. Sorry, I just wanna make this clear for everyone.
Yeah, perfect. This all the points that I would like to mention. The first thing, I will repeat it for the Umar. Umar, quickly in the preparation station, you will find a file that you will write the main points, so you can summarize it for your examiner. You should write your detail firstly, your role, your consultant, and your hospital. Then, who you are calling, the consultant that you are called, and the purpose of your call as IT for urgent patient update or refer. The last thing, the patient details, history, examination, investigation, and management. Okay, so let us start. I think Fatima today she should participate, and Fatah Rahman and Habiba, and then we will start the cycle again. So we will start.
I did not read these stations today, but I will try if I could or not.
Okay. So Habiba.
Yes, doctor. I can start.
Okay. Let me read the scenario. Okay. You open the school. Communication skills.
Doctor, can I use the pen today? Because there's a lot of information sometimes.
Yeah, while I'm reading, you can write the most important points.
Hello?
Hello.
Muhammad.
Yes.
تسنيم خسار عملت حادث. أنا همشي أطلع برا البيت و I will just be listening, okay?
خلاص تمام، ما في مشكلة. السلام.
سلامة يا دكتور.
الله يخليك. One second. You can continue. I will be just.
Okay.
I will be back.
Okay.
Okay.
Scenario. During a post-operative ward round, a surgical resident noticed that a 78-year-old post-mastectomy patient, Miss Janice Green, is experiencing axillary swelling and increased drainage from her wound suction drain. The patient daughter arrived and insists on taking her mother home against medical advice. Despite the resident's attempts to convince her, she still wants to take her mother home, which is 60 miles away from the hospital. What to do? Call the on-call consultant, Mr. Anderson, and update him about his patient.
Who am I?
Okay.
Mm.
You are SHO working with Mr. Man.
There
Mr.
is
Ma-
medical history of COPD and mild left ventricular failure.
Yes, he has a history of COPD and ventricular failure. Okay, left ventricular failure.
And also the amount of the drain, Dr. Muhammad, please inform us.
Yes, the amount of the drain, I think 20
No.
mil, 20 mil, right?
Hello, hi.
Not
I came from
90,
12 hour shift.
90 mil, yes. Ali, please mute yourself.
Yeah. She's had a bit of a fall off her scooter, then I started into it.
Okay.
She feels all right in herself. She's got no.
Yeah.
Her blood pressure took ages to read, and then it was 47.
Ali, I can't mute Ali. I don't know. Ali.
Good.
Mute, okay. So, are you ready, Fatima?
Doctor,
The
you
amount
said
is
she,
90 mil. 90.
you said she has shortness of breath or no?
Yes, he has
Mhm.
past medical history of COPD. I know he has shortness of breath. So let me put the timer
Okay, doctor, I'm working with whom?
again.
You said I'm SHO working with whom?
Who is Mr. Man?
Okay.
Okay, so let me put the timer. You can start.
Okay. Hello, I'm Dr. Habiba, SHO. I'm working with Mr. Man. I'm calling to have a discussion with the consultant on call, Mr. Anderson. Can I confirm that you are the consultant on call?
Yes, I'm the on-call consultant. You can call me Mr. Anderson.
Okay. I'm calling for one of the patients, a 70-year-old patient who had mastectomy with axillary clearance. Her daughter came today and she wanted to take her out against medical advice.
Summarize the whole case, please.
Okay, so Miss Janice Green is 70-year-old. She had mastectomy with axillary clearance. She have shortness of breath and axillary swelling, and she also have increased drainage, 90 mil. She have history of COPD and ventricular failure. And her daughter came today and she wanted to take her out.
So what the
Despite
concern
that,
exactly? The concern?
the concern that she might have complication, especially that the brain is increasing. She might have hematoma and she might have also DVT or pulmonary embolism, and she is living 60 miles away, and the reaching for hospital or
Who lives
medical
60
assessment.
mile away? Is it
Miss
the patient
Jan,
or daughter?
the patient.
The patient.
Yes.
Is it safe to send her home?
No, the patient is not safe to be sent home because we're not sure about the complication yet, and we're not sure that she can reach the medical assessment if she needed.
So what's the concern exactly?
I'm concerned that she might be having hematoma or increased or hemorrhage, or she might have a COPD exacerbation, or she might have pulmonary embolism.
You mentioned that her daughter want to insist her to go to home, right? So how have you assessed Mr. Green capacity to make her own decision?
Yes, I think the Miss Green is capable for retaining information, but her daughter might be having a great effect on her opinion.
What are your findings from the clinical examination?
She had axillary swelling, the increased heartbeat and low blood pressure, and the drainage is increasing for 90 mil. And
Okay.
shortness of breath.
Okay, considering her condition, what are the potential complications? What is your probable diagnosis?
My probable diagnosis could be pulmonary embolism or might be hematoma.
Yeah. Reaction in
Yeah.
hemorrhage lead to hematoma, you mean?
Yes.
Okay. So how you will treat these complications?
First of all, I need to assess the patient. I need to do full blood count, and I need to assess if the patient have DVT by axillary duplex and CT angio. And according to the result of both, I might be doing evacuation for the hemorrhage, or I might be doing extra steps for the pulmonary embolism.
Okay, then you will manage accordingly.
Yes.
Yeah. So how you communicate this concern with the patient and her daughter?
Yes, I explain the risks of the patient having complications. I focused on the patient having symptoms like shortness of breath and increased heart rate. I explained the risk of the patient going out and not be able to access the medical assessment.
Okay. So what would you do if they were insisting on going home?
I would explain for the patient one more time. I would explain the patients the symptoms that if happen, they have to go for medical assessment immediately, like increase in the drains even more, or chest pain. And I will contact with the GP and do continuous assessment until the patient go to her home.
What else important you should discuss with your patient?
I will discuss with patient that she need to um, sign a paper that she is going out against medical advice.
What else?
I will discuss with the patient the complications and the
The
steps.
warning sign and symptoms you
Yeah.
mean. Okay.
Yes.
Yes, okay. It sounds like you are handling the situation. So what are your plans moving forward?
Right now, I will do I will continue physical examination. I will do more blood tests, and I will try to do imaging and chest X-ray and chest CT if I could, and assist the patient until she go out.
Okay. Will you remove the brain?
No.
Mhm. So you should educate your patient about the drain.
Yes.
Okay, perfect. And I think this is the last question that I have. You have 1 minute and 40 seconds. You would like to add anything?
No.
Okay, you can move to the next station. Perfect, Habiba. Very nice performance. Let's review from the beginning. So you start your conversation by introducing yourself and then confirming that you are calling a on-call consultant. And then you say the main purpose of your call that you'd like to refer to update me about the patient. And then you mention all the patient details perfectly from the history. Then you go through the examination, investigation, and the management that you did. And regarding, I repeat the questions of what are the main concerns. You should tell me that her daughter won't or insist her to go to go home.
Okay.
You said it, but not the specific questions which I asked.
Yes.
Otherwise, you answered all the questions correctly, but you need to raise your voice to show some confidence while answering. And I think I helped you In the
Yes.
question of what would you do if they were insisting on going home, you
Yes.
should mention the warning symptoms.
Mm.
Yes, and also the consent.
Yes.
Otherwise, very nice performance. I think you deal with this situation perfectly.
Thank you.
انا ده اقول حاجتين. ده اقول والله يا فتح الرحمن انت وعكاشه طلعتوا شيوخ كبار خلاص. السيشن ده قدر ما ماشيين نزحوا لقدام عشان انتوا دايرينه ليه ترون. شغال تحصل حاجات. انا حقدر اشتغل معاكم لمده ساعه قبل ما امشي المستشفى عشان اشوف الحاصل شنو. فشنو نحاول ننجز يا محمد.
ايوه ان شاء الله بتخلص.
That's very good. We'll leave the discussion at the end. Yes.
Yeah. طيب عندك كومنتس لحبيبة؟
فتح الرحمن. To be honest, I didn't listen to anything, Muhammad. I was with the ambulance.
Okay. So let us move to the next station. Fatima, please unmute yourself.
What is the next station?
Trauma referral for cardiothoracic.
All right.
Fatima, please unmute yourself. Yeah? Okay. Are you ready? I can't hear you, Fatima. Hello. She left the meeting.
Maybe her meeting, maybe her connection. So let's go to Fatah Rahman.
He came.
No. Is it Fatah Rahman?
Yes.
Yes. Let's start with Fatah Rahman and then Fatima will leave her for the last one.
Hello?
Okay.
Fatima, yeah, she's back. Okay. Muhammad, you can start.
Now
This is your session, Fatima, okay? Fatima, are you ready? I think we will. Hello, Fatima. Is there any problem with your internet connection? So this is your station, okay?
Yes. Okay.
Yeah. Let's do it, Muhammad.
Yeah. Scenario: a 45-year-old male post-motorcycle accident present with a GCS of 14. Right while I'm speaking. Pulse rate of 120 beat per minute. And blood pressure of 100/80 millimercury. Examination reveals a swelling left thigh. Chest X-ray indicates widening mediastinum and bilateral hemothorax. Widening mediastinum and bilateral hemothorax. A chest drain was inserted, draining 200 cc of fresh blood. And CT scan delayed due to machine servicing. Further findings include absent psoas shadow on abdominal X-ray and femur shaft fracture. Blood results show low hemoglobin and pH levels. With fluid resuscitation initiated and 6 units of blood cross-matched for pending transfusion. Your task: refer the patient to a cardiothoracic consultant, Mr. Anderson. You are SHO working with Mr. Green in Royal Free Hospital. You are SHO working with Mr. Green in Royal Free Hospital.
All right.
Are you ready?
Yes, ready.
Okay, so let me put the timer.
Can you be the patient, Muhammad?
Yeah, the examiner. I will start.
Okay. Hello.
Hello, doctor.
Hello, I am Dr. Fatima, Senior House Officer, working with Mr. Green in Royal Free Hospital. I am calling, I want to call Mr. Anderson for cardiothoracic consultation. Can
Yeah,
I know confirm that you are the one?
yeah. Mr. Anderson, can you summarize your case, please?
Yes, I have one patient, motorbike RTA involved in RTA, presented with GCS 14, and on examination he has also first of all pulse rate is 120, blood pressure 180/80 millimeter mercury, and he has swelling on the left thigh. We did for him chest X-ray. There is widening mediastinum, and also there is a left hemothorax. We insert chest drain that reveal 200 ml plus blood drained from the chest, and CT machine under surfaces, not working under surfaces.
Okay.
Abdominal X-ray show absence of psoas shadow, and there is fracture femur, left femur. Regarding his hemoglobin is low, and pH is low also. He has metabolic acidosis. We give him, we start for him resuscitation, 4 unit, 4 liter of normal saline crystalloid.
Okay.
And we cross match for him 6 unit of blood.
Okay.
Then not
Why
trust.
this patient being referred to me?
Because there is widening mediastinum in the chest X-ray.
And what does this widening mediastinum means?
Means the patient may have rupture aorta, or
What else?
or we have also
The differential diagnosis you mentioned, aortic rupture. What else?
maybe he have pericardial effusion.
What else?
There is
It could be cardiac component, right?
yes, cardiac.
Yeah. In traumatic aortic injury, which part is usually affected?
The descending aorta.
And regarding the management, what's the plan for the cervical spine and leg injuries?
We should fix cervical vertebra by hard cervical collar and sandbags, and also tape.
And what about the leg injuries?
We should put him in the splint.
The name of the splint, please.
Thomas splint.
Okay. And you should start fluid resuscitation and blood cross-matching as you did.
Yes, we should.
Yeah. What measures have been taken for the patient's blood pressure?
We give him already crystalloid, started the crystalloid for 4 liter.
Here, you should take care of something.
To maintain the
What is it?
systolic blood pressure at 100, not more than 100.
Yes. And potential source of bleeding in hemorrhagic shock for this patient?
There is 3 sources actually from the aorta. It could be from the aorta, from the descending aorta, as aortic dissection, or from the abdomen. Also, in case of absence of psoas shadow, we suspect liver injury or great vessels injury. Also, we suspect also for long bone.
You mentioned long bone, thigh injury. Yes. What type of shock does the patient have?
We have hypovolemic shock.
And other
And also
potential causes of shock in this patient?
Cardiogenic shock also.
Or what else?
Hypovolemic or cardiogenic shock.
Yes, what else? Yeah, obstructive shock. So why did
don't give answer, yes.
Why did the chest tube drain only 200 ml if major vessels injury is suspected?
Can you repeat the question again?
Why did the chest tube drain only 200 ml if major vessels injury is suspected?
Yes, because the bleeding from the pleura is different from the mediastinum.
And what does that
The
mean?
major vessels in the mediastinum.
Okay. What is the definitive management for aortic injury?
Thoracotomy, repair, or endovascular blast.
What? Yeah. Can you repeat? Yeah. Can you repeat again what blood abnormality are present in this patient?
Yes, he have low hemoglobin and low pH.
And why this patient experienced low pH?
Because he has loss of blood, and also he have
Loss of blood, or you mean hemorrhage?
Yes, hemorrhage, and also he have also
Time up.
shock.
Time up, but let us continue our questions. And what else?
He have also shock, type of shock.
Yes, the hemorrhage, which means hemorrhagic shock, and
Yes.
there's a possible cause regarding the fractures in his leg, which is
yes. He have also rhabdomyolysis.
okay. So, what additional investigation would you consider?
We should do band CT for this patient, and also CT chest, CT abdomen, CT pelvis, and also we should do for him CT brain, CT spine, ECG, and echocardiography.
Okay. And regarding the abdomen, what findings suggest further exploration?
Absence of psoas shadow.
Okay. Which indicate that you should do
Laboratory.
Yeah. And what preparation will you make in the ambulance during the patient's transfer?
Yes, we have to prepare CPR set, and also we have to prepare endotracheal tube for intubation, and also we should prepare chest tube in case of the previous one block. And we should accompany by anesthesia.
Yeah. Why you will accompany anesthesia?
Because the patient may need intubation at any time during transfer.
Yeah.
And we need anesthesia to introduce into the
Yeah.
care.
Yeah, the last question in this session. Very nice performance, Fatima. So,
Muhammad, can I just
yeah, you
start?
can. Yeah, you can.
So Fatima, I for the next stations we need the camera open, especially for the examination and for the procedure skills.
Okay.
Yeah, fine. And also, I just wanna make sure that you are studying from school, right?
Yes, from school.
Yes. So I want you also to try to memorize what we written, because I think you forgot couple of very important information. When you say abdominal X-ray show, you should say abdominal X-ray showed instead of just show. The abdominal X-ray showed this and that. It's not the abdominal X-ray show. And you said we give him instead we gave him. You should say we gave him this because you are speaking about the pulse. And also we cross match instead of we cross match. Muhammad reminded you a couple of points. On the exam, your examiner usually will say nothing. So if you're stuck on any question, Fatima, what you should do, you should say, can we proceed to the next question, please?
Okay.
Don't stay silent, because if you stay silent, you're just going to consume your time. Say, yeah, can I get to this question at the end, please?
Okay.
Muhammad also reminded you of the obstructive shock. Yes. Yes, that's the most important point I will say to you. Try to be faster. Try to memorize. When you study with yourself, for example, try to say the answer. For example, ask yourself, okay, what is the differential diagnosis? You literally study like this. What is the differential diagnosis? Cardiac tamponade, aortic rupture, aortic dissection. So you consumed a lot of time trying to memorize this.
Yes.
So memorize them before the session. So when you come, you say them fast. The time didn't allow you to finish because of two reasons. When you're stuck in the question, you don't ask the examiner to proceed. You should say, can we proceed to this question? And the second reason, which is also very important, you don't memorize what's written. If you memorize it, that will make it fast. Yeah.
Yeah, regarding the question of the causes of metabolic acidosis, you should mention Combar syndrome. The patient has leg fractures, and also your patient has a known case of DM. So diabetic ketoacidosis is a possible cause. Otherwise, try to be faster. Very nice performance.
Okay. Thank you.
Fatima.
Aywa.
Muhammad said very nice performance, but we're trying to encourage everyone, but you need to improve on this performance.
Inshallah.
Yes, there's a couple of points you need to work on them.
So, Fath Rahman, the next station.
Yes.
So, Fath Rahman, I will give you points for your patient, okay? Mr. John Smith, a 55 years old. The procedure, right hemicolectomy performed 24 hours ago. He presented with reduced urine output, 20 ml over the last 8 hours, the urine output. He have tachycardia, low-grade fever, mild hypotension. On examination, the finding is lax abdomen, moderate, his investigation also, dropping his hemoglobin from 12 to 10. Moderately raised urea, borderline high creatinine. So you gave your patient 100 1,100 ml of normal saline since surgery. Your task: call the on-call consultant, Mr. Lee, and update him about your patient and seek advice. You are ST1 working with Mr. Green in Royal Free Hospital. You have 8 minutes and 40 seconds. Are you ready?
Royal Free Hospital.
So let me
Okay.
put the timer. You can start.
Hello.
Hello.
Yes, I'm Dr. Fathar Rahman, ST1, working with Mr. Green in Royal Free Hospital. I'm calling the on-call consultant, asking for advice regarding one of the patient. Can I confirm I'm calling the on-call consultant?
Yes, I'm the on-call consultant, Mr. Lee. Can you call me Lee, please?
Nice to talk to you, Mr. Lee.
So summarize your case, please.
Yes, I have Mr. John Smith, 55 years old. He's post right hemicolectomy for sickle tumor 24 hours ago. I consider that the patient have decreased in urine output. His urine output about 10 to 20 ml for the last 8 hours. Also, patient is tachycardic, with low grade fever and mild hypotension. My examination, there is lax abdomen, and his investigation showed drop of the hemoglobin from 12 to 10 gram per deciliter. He had a moderate rise in urea, borderline high creatinine. Besides that, the patient, he received only 100 ml of normal saline since surgery, despite his noted blood loss, and he received 2 units of blood transfusion during surgery.
Is this patient in shock?
Yes. Yes, according to his signs and symptoms, I'm expecting patient in hypovolemic or septic shock.
What do you suspect is causing the oliguria?
Most probably dehydration. The patient received only 1,100 ml of normal saline since surgery.
And what are your plans of action?
Initially, I approached the patient according to care of critical surgical ill patient using ABCD approach. Then I will initiate fluid challenge. I will give him 250 ml to 500 ml and assess the response.
What is the purpose of the fluid challenge?
To address shock, I will initiate the fluid challenge in a dose of 20 ml per kg.
Okay. Does your patient require an HDU transfer?
Yes. As the patient is dehydrated now, and he needs after the fluid challenge and reassess response, I will order blood test, and if no response, I will contact HDU for transfer for central line insertion for monitoring.
So if HDU is full, who will you speak to?
I will contact the bed manager, discussing the possibility of discharging the potential stable patient or repartition of the patients.
So, do you suspect bleeding or anastomotic leak?
It is possible, but I will continue monitoring and see the response of fluid challenge. And I will do blood investigation. Also, I will ask for abdominal ultrasound, and if any sign of peritonitis, I will let you know.
You mean you will do an examination for your patient?
Yes.
Serial abdominal examination. Okay.
Yes.
Does he require an operation now?
It is possible, as I'm suspecting peritonitis. I will see the response, serial examination, vital sign assessment, and the response for fluid challenge. If I continue to have dropping in hemoglobin, I will initiate blood transfusion after discussion with the hematologist.
Okay. Does the patient need hemodialysis? And what are the indications?
No, I rule out the need of hemodialysis, and the indication is severe acidosis, which is pH less than 7.2, also uremic encephalopathy, and persistent hyperkalemia of a potassium level more than 6 millimole per deciliter.
Okay. And the last question that I have, would like to add anything?
No, thank you. I just need to summarize our discussion. I will continue monitoring of the patient. I will start fluid chilling, assess the response. If no response, I will need the patient to HDU and repeat labs. I will consider to do abdominal ultrasound, possibility for centralization for monitoring. If any site opportunities, I will update you at time.
Okay, thank you, Mr. Fath Rahman, for the detailed information. Please proceed with the referral.
Thank you. Thank you.
Okay, perfect.
How many minutes remain؟
3 minutes.
صببت على السنة الثالثة يا فتح الرحمن.
ما شاء
والله
الله
ما
تبارك الله.
تبارك الله ما نقول عليه. Yes. Yeah. So I think you mentioned word by word what we written.
Yes.
You just added the blood transfusion.
No.
Yeah. The blood transfusion was with the HGD discussion. There's just two small mistakes. One of them, I grammatically you said I consent instead of am consent. Am consent. I consent.
Yes.
I'm concerned of this and that. You said it twice, I think. And the indication for dialysis are, or most important indications of dialysis are this and that. Okay? This is not all the indication for dialysis. Indication for dialysis are 9, but we brought here what's related to the station. Okay? There's more than 10 or 9 or 10 indication for emergent dialysis.
Overload is not one of them.
Sorry?
Overload. In this
What?
case.
What did you say, Omar?
Overload.
This patient is hypotensive.
Yeah, the patient is hypotensive. That's why we didn't mention the overload. But they are 9. The patient has shock, which may lead to acidosis. The patient has renal problem, which may lead to uremic encephalopathy. And also his potassium was deterred. On the exam, they won't ask you for the 9. They will just ask you to mention 2 or 3 for the emergency indication, emergent indication for hemodialysis. But I think, Muhammad, we can just put the 9 of them just in case.
Yes.
They didn't ask about it before, but we can just put all the indication for dialysis in one place so people can remember it. I'm going to add this now. If you can continue the discussion, Muhammad.
Yeah, Fath Rahman, very nice performance. You mastered the session. You remind me by main point with the conclusion and summarization of your discussion. So guys, regarding the phone calls, if you end your station and you have 2 minutes or 1 minute remain, you can ask your patient, I would like to summarize the plan of management for you, if I can. Then after summarization, the management, thank you for your time, Mr. Lee. Thank you for your time, Mr. Fath Rahman. Thank you for your time. Thank your consultant at the end.
Yes.
Okay.
Yeah, because he's the one who's giving the
summarization of the discussion. I think they give her 50% of the professionalism.
Yes, only the plan of management.
Yes, plan of management.
Yes.
To be honest, yeah, summarization is more important for the person to person. Here, they will give you mark whenever you answer each question. But if you have time at the end, you can just say, just to summarize what we said, I will do this and I will do that.
Yeah. So should we go to the last session today, which is perforated viscous, ITU registrar? So the cycle will start again. Who will practice First
I
one in the
think
last
I think
station.
it's Muhammad
Akasha or
Siddiq.
Sadiq. Akasha or Sadiq. One of
Yes.
them.
Who's ever ready? The first one will say. Someone is left the meeting. Who is it?
Mobile duct injuries station.
No, I mean not all our team is here, right? Umar is here, Muhi is here, Habiba is
I
here.
think the bile duct injury.
Yes. Are you
لو
ready?
ماشيين بالدور عكاشة، لو ما في أنا ما عندي مشكلة.
عكاش شكله بيزي شديد الليلة.
خلاص تمام. انت الليلة والمرة
وبكرة
الجاية عكاشة وتدور السايكل كده.
Okay, let's start.
طيب. محمد صادق. سيناريو. Mr. Wilson is a 71-year-old man with a
دي
background
دي البايل دكت انجري ولا؟
perforated viscous ITU registrar.
No. The plan is bile
بايل محمد.
Bile.
Yes.
Okay.
هو غايته مكتوب في الكالندر بايل.
Yeah. We will practice bile.
Yes.
Sorry.
Always look, calendar is our guideline. Calendar is calendar. Let's do the bite.
So, scenario, Mr. Lewis had a cholecystectomy 2 days ago, and the surgery went well. However, after the surgery, he started experiencing more belly pain, and there is a bile in the abdominal drain. Clinically, the patient has tachycardia, fever, and jaundice. Abdominal examination unremarkable. Blood investigations, C-reactive protein 40. White blood cell elevated, bilirubin raised. Please note, this blood investigation done 2 days ago. Imaging, abdominal ultrasound showed free intraperitoneal fluid. ERCP not available. Also, please note, C-reactive protein. The first C-reactive protein test is 60, and this C-reactive protein is 40. You have 8. You are a CT working for Mr. Lee. CT1 in Royal Free Hospital. You are calling and you are calling Mr. Jack, who is a hepatobiliary consultant, okay?
Asking for further management. Okay, I will be the consultant. Muhammad, with the timer. Let's
Refer
start.
the patient, okay. So
Lewis, his age come 45.
Lewis 45. You can imagine at 45. Yes. Are you ready?
Yes.
So you can start.
Muhammad, meanwhile, can you add the emergent hyperkalemia on the other station, please?
Yeah. So let us.
Okay.
You can start, Muhammad.
Hello, I'm Dr. Muhammad. I'm ST1 doctor working with Mr. Lee in Royal Free Hospital. I am calling to speak to the hepatobiliary doctor, hepatobiliary consultant, to refer one patient underwent cholecystectomy 2 days ago, and we suspecting biliary tree injury. Can I confirm that I'm talking to the hepatobiliary consultant, Mr. Jack?
Yeah, I'm Mr. Jack. I'm on call today. Yes, so tell me more about your patient, please.
Nice to meet you, to talk to you, Mr. Jack. My patient, he's 45 years old gentleman. He's Mr. Lewis. He underwent cholecystectomy 2 days ago. Since operation, he experienced abdominal pain, and also we noticed that there is a bile in his abdominal drain. in our abdominal examination is almost normal, but the patient vitally, he is tachycardic, febrile, and also he experienced jaundice. Regarding blood investigation, he has his white blood cell is elevated, as well as elevated bilirubin, and also he has raising CRP.
Yeah. So what's your impression, doctor? What do you suspect?
Actually, sir, I'm suspecting this patient as he underwent cholecystectomy, and if you're considering the bile in the drain, we suspect biliary injury.
Okay.
Furthermore, we did abdominal ultrasound, and it showed that free intraperitoneal fluid collection.
All right.
So
now I do understand. Yes. Thank you for doing all of this. I just want to know if this very urgent situation, is it just now or what exactly? Why is it an urgent situation?
Actually, sir, yeah, it is an urgent because we're suspecting biliary injury and we're fearing from the peritonitis. So it is urgent for us.
Fine. Can you define the biliary peritonitis for me, please?
Yeah, biliary peritonitis is inflammation of the peritoneum due to bile in the intraperitoneum.
All right. And can you tell me possible causes of biliary peritonitis?
Yeah, this could be due to from cystic, slipped from the cystic duct due to slipped clips or retained CBD stone. Also could be due to injury to the biliary tree in general, or even from the perforation of the gallbladder. Also, it could be from the liver bed itself.
All right. Okay. Did you perform a CRB?
Yeah, CRB, it showed elevation first, like 80. Yeah.
Yeah. So CRB is 80.
Yeah. It's
okay. Why do you think CRB is elevated? Could it be an infection?
If we consider that this patient is he underwent recent surgery and the CRB is is a C-reactive protein and is inflammatory marker, so it's suspected to be elevated post-surgery, but even now, sir, it is trend to decrease because the second result is from 80 decreased to 60.
All right. So you think it's post-operative CRB, and you don't think it's more of infection? Fine.
Yeah, we think that the symptom is more fit to the biliary injury more than
fine.
infection.
Fine. And did you check his white blood cells?
Yeah, we check his white blood cells. It is elevated about 7.
Yeah, by the way, I just wanted to ask you, these blood tests, are they from today?
Unfortunately, sir, it is done 2 days ago. And I'm assured you that I will do a new set of blood investigation as soon as finish from this call.
Yeah, to be honest, that's a very old blood we need a recent blood just to have a recent picture of exactly what's going on. Okay, yeah, so sure. What are you planning to do?
I'm planning first to address the patient with fluid. I will give him IV fluid, crystalloid. Also, I will cover him with antibiotic after discussing with the microbiologist. Also, I am considering to do ERCP, which is unfortunately not available in our hospital, to know the cause of this leak.
Okay, why do you want to do ERCP?
to delineate the anatomy of the biliary tree and to figure out the exact reason of the biliary leak, and also for possible intervention treatment.
All right. Can you tell me how ERCB is done and what exactly ERCB stands for?
Yeah, ERCB is, it stands for endoscopic retrograde cholangiopancreatography, and it is like a flexible tube inserted through the mouth until the duodenum, and at the duodenum, exactly in the ampulla of water, we will inject the dye there. Through the dye, we will see in the screen it will show us the common bile duct, the hepatic duct, the cystic duct, and even the gallbladder. And we will know if there is a leak for dye. We can locate the site of injury, or even if there is obstruction, also will appear.
All right. Let's say we injure the common bile duct, and it's now a serious issue, and that's a really biliary leakage, and you're afraid of peritonitis, as you said. What is the definitive management, or give me some of the options that you may consider as a management for such a patient?
Yeah, actually, we can treat this patient according to we can put just a stent.
Okay.
Other option, surgical, surgery. The aim is to ensure the continuation of the biliary flow. We
Okay.
have surgery called, ROX Y chlorhydrogynostomy,
Yeah.
I think. Also, we have another option for, direct anastomosis, which is I think duodenoscopy, DD.
Okay.
We have a lot of surgery, like 2 or 3 options implicated in such case.
Fine. Okay, that's fine for me. No, there's currently no available beds in the hospital, and if we did this operation, we don't have we don't have ITU beds. How would you recommend?
Time up, but continue.
Yeah, I recommend. I will contact with 2 hospital bed manager and insisting that, and I will explain the importance of transfer. Also, I will insist to the bed manager to try to discharge the stable patient, or even repartition the bed in the ICU.
Okay, fine. I think that's most of my questions. Thank you, Doctor. You can proceed to the next station.
Thank you so much, sir, for your time.
All right. Good, Muhammad Sadiq. You may think that you didn't perform very well, but you did very good. You answered all the questions. You've been professional, very clear in your communication. You answered most of the questions in a very good way. I think the most important serious mistake is you forgot CRISP in general. Yeah, that's it. You treated it as an experienced clinician, which is fine, but these people need to hear some words like CRISP so they can give you the mark, because critically ill surgical patient. He is, instead of he is tachycardic, you said he is a tachycardic. You either say he is tachycardic, or you either say he is a tachycardic man or a tachycardic. So is neither صفة لازم تجيب لها صفة. He is tachycardic. You said we are feared of. That's not wrong, but usually it's better to say we are worried of biliary leakage. You, for this station specifically, is a difficult one. It's a very long one, and it has very strange names. So what I would say, go to YouTube and write those 2 stations. This I cannot pronounce it. I'm going to be clear with you.
Yeah.
Roxin Y.
Roxin Y.
Roxin Y.
Yes, I could. Fatah Rahman. I do traction of the bones. I could not pronounce this one. So go to YouTube, write.
يا رخص ماي ولا ريح ماي فرنسيه صح ولا؟
Yes, so just listen to it and learn how to pronounce both of them.
Okay.
When you define the ERCB for me, you mentioned everything right in a very simple way, but you said you will look to the screen without telling me that there will be an X-ray that will allow you to see on the screen. So X-ray is a very vital word in your explanation, okay? But all of this will not cost you more than 2 or 3 marks maximum. But we're trying to avoid this. Today, I think you said a lot, Muhammad Sadiq. I don't know why. Maybe you just studied it quickly, but you used to be faster than today. The time didn't allow you to finish the station, which is not ideal. You should finish the station and have like 50 seconds minimum. I think you're trying to remember, so still do some memorization of what's written, so you will be allowed to finish the station within the time. Okay. And you thanked me at the end, which was very nice. You know, now I'm your examiner, right? I feel good when you thank me at the end, and I think that's what's going to happen also to your examiner. Thank you, Mr. John, for your help. This will give you 2 marks extra. I feel it now.
Yes.
Fine. Muhammad, if you can continue.
Yeah. There I have just one point. Very nice performance, Muhammad Sadiq. You mastered the station. The only thing I would like to add, which is regarding when Ali asked you when were those blood taken, you reassure the examiner perfectly and you apologize for this point, but also update him, as you should say, I will update you. I will reset the investigation and I will update you. This will increase the mark of performance. Otherwise, the crisp and the time didn't allow you to answer all the questions. So be faster, more than this, and you will not be asked all these questions. But we wrote these all questions, so if you face it, you can answer. Otherwise, perfect.
يلا محمد leave the recording on. يلا يا جماعة والله